Next on primary care, population health. It's gaining momentum as a way to improve health outcomes in vulnerable populations.
You drop 2 millimeters of mercury of blood pressure to population level, you'll prevent almost 50% of heart failure cases in African Americans.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health of African Americans. We doctors have known for some time now that social determinants of health, the things that happen outside the doctor's office, have a significant impact on our patients' health. In fact, research suggests that the medical care accounts for only 10 to 20% of health outcomes, while the other 80 to 90% are caused by demographic, environmental, and socioeconomic factors. Population health is one approach that addresses the 80 to 90% and is being used by my next guest to reduce the high prevalence of hypertension amongst African Americans. Joining us today is Professor Phillip Levy. Dr. Levy is the tenured professor at Wayne State University, where he currently serves as Assistant Vice President for Translational Sciences and Clinical Research Innovation. Dr. Levy is also Chair of Research in the Department of Emergency Medicine. His research centers on health disparities related to hypertension and hypertensive heart disease. Dr. Levy, we're so happy to have you on the show.
Lonnie, it's my pleasure to be here. I really am grateful for the opportunity to come talk with you.
It's our pleasure to have you. Population health has been a term that's coined a while back and been around for a while, known by healthcare professionals and a lot in healthcare circles, but the general population may not be familiar with this. Help our viewing audience understand what population health is.
Absolutely. I think oftentimes it gets conflated with public health, and public health is really how do you assure that the population maintains health, things like food safety, water safety, vaccinations, those types of things. Population health, on the other hand, is the confluence of circumstances that help that assurance occur. And in some respects, it's about the health care that's delivered and the health of people, but it really involves all the upstream risk modifiers. So as you started out mentioning in the show, it's the socioeconomics, it's transportation, it's environmental factors, it's all of those other things that we don't often account for as physicians when we're delivering care at the bedside. It's very easy when a patient comes into your office and says, I have high blood pressure, and you say, here's the medication you're on, let's increase the dose, but it's much more difficult to understand all of the backstory that sits behind that person, whether they can get the medication, whether they have other stressors, as you and I were talking before the show, right? How do you know when somebody's facing eviction? That's not part of what we do as doctors, but that's part of population health, understanding all of that and how it affects the ability to achieve health and wellness in a population.
So for me to write Ms. Jones a prescription who's facing eviction, and me thinking that this 10 or 20% worth of treatment is going to affect an outcome called controlling her blood pressure, is probably only going to be 10 or 20% effective.
Yeah, it's very difficult. Certainly you can give the medication to the patient, but if the patient can't get the medication because they have socioeconomic concerns, if they have other stressors in their life, if they have marital strife, if they have communal strife, if there's anything else going on, that's going to have a bigger impact than just the medication alone. I had one of my research patients following up the other day, 52-week study, the guy's been doing great the entire time, comes for his final appointment the day a family member had passed away. And of course his blood pressure is elevated. And so we're saying, well, that's not a real representation of what happened to you during the study because you did so well up until this moment. And so really appreciating just the magnitude of how those other things affect conditions like hypertension is critically important to doing our job most effectively, but having patients be able to self-manage their conditions.
We've known for a long time now that the side effects or the effects of having uncontrolled high blood pressure, end organ damage becomes real. You mentioned hypertensive heart disease as one of the areas that you focus on in your research. How does that translate to an area like Detroit?
First and foremost, people in Detroit are 30 to 40% more likely to die of heart disease, hypertensive heart disease, or hypertension is the cause of heart disease specifically, than anywhere else in the state of Michigan and compared to the rest of the United States. And so much of that is attributable to hypertension which for the vast majority of people, even though we get concerned about resistant hypertension, meaning difficult to control hypertension, that's really few and far between. It's maybe 10-15%. Most of the time we have patients whose blood pressure is uncontrolled, and it's all the social factors that we're talking about, plus a little bit of clinical inertia. Doctors don't always treat it as aggressively as they should. But when that occurs, it's sort of a travesty of population health, because hypertension is something we all know about. Whenever the American Heart Association or American College of Cardiology talks about it, it's awareness, treatment, and control. Everyone's aware of hypertension being a problem. A lot of people get treated, but getting controlled blood pressure is a real big challenge. And so in order for us to really better understand how to control blood pressure, we have to step back and say, okay, let's work backwards. We have a huge problem with heart disease. It all traces back to uncontrolled hypertension. How do we get hypertension, first of all, prevented if we can, but if you have it, how do we make sure it gets controlled by accounting for all the other variables that we don't typically account for?
So if we only treat adequately, and we question that sometimes,
right,
20 to 30%, how do we get a passing score? How do we get a good report card on a disease state like hypertension?
It's so difficult. And part of the challenge too is that a lot of times those report cards and those grades and how we look at the quality of care delivered is based on a single point in time office measurement. And as we're both aware over the past few years, and certainly since the new guidelines came out in 2017 from the AHA and ACC, home-based blood pressure monitoring and ambulatory blood pressure monitoring are critical to not just understand what is your pressure when you came into my office today. I always use the sort of, the comparison when we go to the dentist, right? My dentist knows that I flossed once the night before I came because he can see my gums are inflamed, right? And so if a patient's going to follow up with you in your office for their blood pressure, maybe they'll take their medications a little more diligently the day before because they know you're going to call them out on it and say your blood pressure is uncontrolled. But what's happening 24 hours a day on every other day? And that's why it's so important to get the information outside the healthcare setting, outside the four walls of our offices, or in my case, the emergency department, and say, okay, this is what's going on at home. And while this was going on at home, what was going on with you? Were you experiencing some stressor? Was there something else in your life that we need to understand so that we can, again, best affect your treatment?
We're here in Detroit, and on a comparison basis, we probably got some issues.
Yeah,
okay,
that's for sure.
Speak to us about hypertension, hypertensive heart disease. How are we doing?
So in short, we're doing very poorly. And I think everyone, all the viewers on your show and everyone in the medical community knows that African Americans are far more likely to develop hypertension than other races and ethnicities. A lot of that has to do with genetic predisposition, but a lot more of it, as we were describing, has to do with the social circumstances, things like structural racism, or things like the socioeconomic circumstances, poor educational opportunities, lack of upward mobility and employment, all the other things that very difficult to solve, but really important to understand. But the key thing, and maybe I'll walk you through a little stories to understand why the heck you have an ER doc up here talking about hypertension. So I came to Detroit from New York, and I worked at Bellevue Hospital in New York City, and I never saw the heart disease that I saw when I arrived in Detroit and New York. And as an ER doc, it was really great for me to be able to deliver the best care I can to a patient who comes in with acute heart failure. And I did a lot of research early on in that area, but kind of started looking at it and saying, why am I treating 50-year-old men
with heart disease?
With heart disease when they're 70 or 80 back in New York? And we started looking at the relationship between hypertension and uncontrolled blood pressure on patients who present to the emergency department, and started doing echocardiograms on these patients, basically heart ultrasounds, and found that amongst almost 200 people who had no history of heart disease but had high blood pressure, 90% of them already started having remodeling of their heart. They started developing the cardiac or the heart consequences of elevated blood pressure. And this hypertensive heart disease is the ticking time bomb, because that leads to overt heart disease, which then puts you on a pathway to die of heart disease. And if you're 75 or 80 when that happens, that's horrible. But you lived, a good 7-8 decades, that's pretty good. If you're 50 when it happens, you're sapping the vibrancy not only of that individual, but you're taking life out of the community.
That's the science.
Yeah.
But when we add the social aspects to it, I'm sure that we get a synergistic effect to that. Dr. Levy, we're up against a break. We'll be right back with more primary care and Dr. Phillip Levy.
As we stay home to do our part flattening the curve, it's important that we remember our personal mental well-being as well. Each day, create a schedule for yourself so your mind stays sharp and active. Be sure to set aside time to stretch, meditate, or exercise. And stay connected to others in new ways or old. It's little things like these that will keep us all strong and in the fight together. For the latest updates on COVID-19, visit uofmhealth.org.
Welcome back. We're here continuing our discussion with Dr. Phillip Levy, Associate Chair of Research in the Department of Emergency Medicine here at Wayne State University in Detroit. Phil, help us get deeper into this concept of social determinants of health and population management. How are these issues best addressed, such as hypertension? How are these issues best addressed by the population health approach? And chime in on this Phoenix project that seems to be very exciting. That's getting going here in the area.
Yeah, I'd be delighted to. This is the culmination of my life's work, or at least getting towards it. So, we were talking about emergency department patients and having early onset subclinical heart disease and being ticking time bombs for developing overt heart disease. So taking a step back for a second, we know based on multiple national level data that a 1 or 2 millimeter of mercury reduction in blood pressure at the population level has a dramatic impact on health outcomes. So that's not you or I going from 137 to 135 systolic.
Exactly.
It's taking thousands of people and seeing the whole thing drop 1 or 2 millimeters of mercury. That means someone's going to drop 40 millimeters, someone's going to drop 10, someone's going to rise 5, whatever it is, it averages out to 1 or 2 millimeters of mercury. If you do that, if you drop 2 millimeters of mercury of blood pressure at the population level, you'll prevent almost 50% of heart failure cases in African Americans.
This is not just an insurance actuarial calculation. This is something that we count on in delivering health care.
Exactly. And really the question is, how do you ever know at a population level what you're achieving? And so in the HIV world, they have developed a concept, something called community viral load. A lot of this has to do with the fact that HIV has a ton of funding behind it, Ryan White Foundation funding and the like. But bottom line is that in a community, you can know what the overall viral load is, which is the amount of virus in someone's body, which is an indicator of how effective HIV care is. And the better your viral load is, or the lower the viral load is at the community level, the better your HIV care is. So we started saying, can we do this for hypertension? Can we understand what the community pressure load is? And as you can imagine, that's really challenging. How the heck do you ever find out what are all the blood pressures in communities? So being an emergency physician, we started saying, hey, we know one thing that occurs for everybody who walks in the door of an emergency department, we get blood pressures. So we started aggregating blood pressures to understand the community pressure load in the Metro Detroit region. I work at the Detroit Medical Center as an ER doc at Detroit Receiving Hospital. We have a lot of close colleagues and collaborations with Henry Ford Health System too. So we started aggregating data on all of these individuals who present to emergency departments, and then geographically representing that by census tract, which is a smaller geographic allocation than zip code, but it's about 2,000 to 8,000 people in size. And what you get there is an idea of where does uncontrolled blood pressure, or how do blood pressure differences exist across communities, and why do those differences exist? That's where you get the social determinant information. So we started doing this. We've now mapped out over 600,000 blood pressures from emergency department patients across the city of Detroit. And we have a really good idea on where pockets exist, where blood pressure is worse controlled or better controlled. But really the key to this from a population health dynamic is overlaying the social determinant data. So starting to pull in information on housing security. So we work with partners to understand tax liens and foreclosures and evictions, looking at food security, looking at crime data, looking at air pollution, looking at poverty levels, and all these different factors, hundreds and hundreds of them that you can think of, so that we can start to understand where differences exist, what contributes to those differences, and get at where we might be able to intervene, not in our offices and not in the ER, but in the community. How do we know what matters to community members? How can we help inform them what the data say, and then collaboratively work to create solutions?
So after Mrs. Jones swallows her antihypertensive medication in the morning, she's got 23 and a half hours the rest of the day to deal with all of these determinants of health that affect her blood pressure,
right?
The other 80 and 90%.
Right, and then Ms. Jones just received a foreclosure notification because she has a $3,000 tax lien on her home, and that foreclosure notification 2 months down the road leads to eviction. During those 2 months, how the heck is Ms. Jones ever going to control her blood pressure, because she's fearful of losing her home? Then once she gets evicted and she doesn't have a place to store her medications, maybe she suffers a heart attack. And so you just took a $3,000 tax lien and created a $300,000 medical condition. Without understanding the connection between it, policymakers aren't appreciative of that. We as physicians aren't appreciative of that. I have a new patient who just showed up in my ER with a heart attack. It's your patient at home with uncontrolled hypertension, but all of this fits together. And so what we want to do is start to pull all this information together in a way, creating this program called Phoenix, the Population Health Outcome and Information Exchange, and start to look at the confluence of all this information, all the health data that we have available, protecting people's information. We understand the need for privacy, but we have to understand why community A is different than community B, and the solution in community A is very likely to be different than the solution in community B. But you have to have information to do that.
So we collect the data. Can we implement it properly to get the desired outcome?
Yeah.
I mean, can we tell this story in the proper settings, the proper boardrooms, around the proper tables, that this needs to be explained to in detail to actually get the decision makers to make decisions that will affect change down the road. So 5 years from now, we can say, listen, the comparative studies say we've reduced this disease state, we've prevented these incidents from occurring, or are we saying more of the same?
It can't be more of the same, right?
Exactly.
We don't want more of the same. What we need to do, and my whole mission in life, honestly, at this point, is this understanding of heart disease death in the city of Detroit. To affect that, it's a 15 to 20 year horizon, because heart disease death develops after heart disease incidence, which develops after uncontrolled hypertension. So to make that change, you have to look where you want to go, but start where you're at. And by starting where we're at, combining all these blood pressure data points, we can identify the communities. By combining all the social determinant data, we can go into the communities, work with community members to say, this is what we're understanding, is this what you're understanding? And if so, what do we think collectively we can do about it? Target interventions that community members believe in and that they want to see happen. And sometimes those interventions are not what we think they are. Sometimes it's creating a boulevard with walkable sidewalks so that people can get out of the house and feel safe. Sometimes it's neighborhood groups getting together and doing watch programs so that people feel safe and don't have that heightened concern for violence or whatever it might be. But then by pulling all the data together, we can track the outcomes over time. And we can do it in a way that says, we did this intervention in March of 2020. A year later, we saw blood pressure decrease in the community, and we saw a decreased incidence of heart disease.
I know that this exists in a lot of arenas now. Tell us about the other partners that you have in this Phoenix project.
It's really exciting. So initially it started off with this idea of working with the health systems that we know and collaborate with. But in order to really get at true population level data, you need true population level data. We have a really unique thing in the state of Michigan called the Michigan Health Information Network, which is an aggregator of data based in Lansing that is a collaborative, but it basically is a way for every health system, because all health systems participate, to share information on health encounters so that you can best understand certain things, certain dynamics around all of this. It was initially developed to help things like Blue Cross Blue Shield get to their pay for performance metrics and other aspects of it. But really what we're saying now is, can we pull these data points together so that we can have a better understanding comprehensively of the population, and then share that information with the health systems. And you asked before about how do we affect change down the end? You have to know your audience. And so for health systems, they want to know, are they delivering the best care to their populations? It's really hard when a health system gets dinged for doing poor performance when all these social determinants are contributing to that. It's not fair in your office if all your hypertensive patients aren't meeting their goals, which I'm sure they're not, Lonnie, because you're such a good doctor.
No, they're not.
But it's not fair if everybody who you take care of has all of these other factors that preclude the ability to effectively deliver health care.
The report card for anybody can't be meaningful if the meaningful use of the terms are not identified and can be applied accurately to what the situation is. You're not going to get certain people to exercise. That's
Right.
not going to happen.
Right.
You're not going to get certain people to change their diet. That's not going to happen. So it can't just be the yes or no answers any longer. It's going to take drilling down on a lot of this data to get us where we really need to be. Dr. Levy, we wouldn't do this topic justice if we did not draw into this the other players in the game. Just like there are other factors related to healthcare delivery for the patient, such as the social determinants of health. There are other factors in getting us to the point that we can actually deliver that, such as the insurance companies, the healthcare systems, the politicians. How does that factor into this whole discussion?
So it's critical because we were talking before about knowing your audience, and if we want to appeal to community members, patients, providers, that's one way or one direction we have to address. If we want to appeal to policymakers, we have to speak their language. If we want to appeal to insurers, we have to speak their language. And so inherent with all the work we're doing with Phoenix is understanding the econometrics of this. So in order to forgive someone's tax lien for $3,000, you have to show that it has the downstream costs that are far outside that $3,000, but how much does it cost to do that? So in one community, foreclosures may be the thing. In another community, it may be food isolation. How much does it cost to get a Whole Foods to come into a neighborhood? How much does it cost to get a Gleaners to participate in food delivery services? So understanding the cost is a critical equation, but not the cost necessarily of delivering the health care, but the cost of fixing the social determinant problems. The city of Detroit is entering a very unique time right now where 7 corporations have agreed to fund specific communities in their Detroit Neighborhood Health Initiative. And the things they're looking at are not necessarily healthcare related. It may be the built environment, it may be streetscapes, whatever it might be. But there's a broad interest in knowing how that impacts health, because if you spend a certain amount of money to fix a theater or to fix something that people will feel better about their neighborhood for, that could have downstream implications for health outcomes. And if, again, fixing a streetscape, which leads to more walkable environments, leads to improved blood pressure control, which reduces heart disease incidence, the econometrics will support that upstream investment.
So in other words, Phil, there are things that we have done. There are things that we do, but there are also things that we have failed to do. There are entities that we have failed to include. There are people we have failed to include. There are communities that we have failed to include. That's how we got into this situation that we're in now.
Yeah, it's a siloed mindset. So just by way of example, as an ER doc, right, most of my colleagues don't want to think about population health. They want to think about their job, their shift is over, and go home. But how do we say, yeah, that patient who showed up today with their ankle sprain, we give them some Tylenol or Motrin and they go home with an ACE wrap. The real issue is not your ankle sprain. The real issue is that your blood pressure was 200 over 100, and it's been that way in the other 5 ER visits you had over the past 3 years, but nobody's stopped and said, we need to do something about that. And that's really where our approach is a little bit different. We're starting to say, okay, if the docs don't want to do that, somebody's got to do it, and it's got to be a societal understanding that this is really important. We're starting programs working with the state of Michigan and the Michigan Department of Health and Human Services with CDC funding to put community health workers in emergency departments. There's not reimbursement right now for community health worker activity, but there should be down the road, because community health workers are community members who can help people get where they need to be. So we embed community health workers in ERs and say, okay, great, this patient has uncontrolled hypertension. It's now your responsibility to link them to active care so that they can get this managed, because that's going to help everybody in the long run. The more people stay vibrant and living well longer, the more the communities benefit. One of the numbers that I always like to share that's astonishing is 25% of the city of Detroit's on disability. That's not all back pain and injuries. That's
Correct.
People developing strokes at age 45.
Exactly.
That's people on dialysis. That's all these individuals who had something bigger than the silos existed, a bigger vision, maybe that could have been prevented. And everybody who goes on disability is no longer contributing to the tax base. If you want a vibrant community, you have to have vibrant people living long, healthy lives.
So we have to go back to access. What percentage of people, I know we tossed these numbers around years ago, but what percentage of people currently seek their primary care in the emergency room?
That's a tough one because it varies by different communities, but we know that in cities like Detroit where primary care access is limited, and when you try to get primary care appointments, it seems the person who answers the phone, not in your office, Lonnie, but the person who answers the phone often has a role that is focused on putting you on hold as long as possible, as long as tolerable.
Right.
And what does that tell to the community? You don't matter.
Right.
And so where do they go? They go to the place that says our doors are always open, and we don't ask you for a payment before we see you, which is the emergency department. So in some ways, we have created a system that addresses the failures of our larger primary care. But I would tell you, we see a tremendous amount of people in the emergency department who come there strictly for primary care purposes. When I submit papers for publication and write grants, and I talk about people coming to the ER for hypertension management, reviewers who don't work in these circumstances can't believe it. That does not happen.
The numbers, they're blown away by the numbers.
They're blown away. And African Americans are about 1.5 times to 2 times more likely to use emergency departments for primary care compared to other races and ethnicities. And when you do that, you can imagine the health outcomes are much worse.
And much more expensive.
Exactly.
Right. What's on the horizon? I always like to end, most of the time at least, like, what can we expect in the future? What's coming down the pike in terms of population health?
So the vision down the road for population health is really one of collaboration. It's really one where we're in an era now where we have much more data and information than we've ever had possible. Now we have to make sense of it. And we have to make sense of it in a way that's actionable. And it has to be actionable to different stakeholders.
Right. We just don't want to be victims of information overload.
Exactly.
Right.
So we have to figure out how to distill it down to the right way. So how do you tell a community member, how do you teach a community member what the heck population level data mean? How do they understand the importance of whatever factor, structural racism or whatever, in their ability to control their disease state, and what do they think can be done differently about it? How do you get healthcare providers to stop thinking about their silos and say that's someone else's problem, it's not my problem?
Exactly.
Right? You use the example, off camera about I don't do windows, I do floors, right? Well, you know what? We all do floors and windows because patients are holistic, right? And so we have to think about it that way. So I was just working with the state's Oral Health Commission on blood pressure management or identification in dentist office. That's something that dentists aren't trained to do necessarily, but they see people who have health and health problems.
Right. Some of these things we don't need to reinvent. I mean, remember the barbershop projects that we did? Yeah. I mean, we measured blood pressure and found all kinds of associated and related diseases just by checking blood pressures in barbershops. Phil, we could go on and on and on with this. This is an outstanding concept. We're really looking forward to what this kind of approach brings to us 5 years from now, and to look back and say, boy, we did it. This is outstanding. Thank you so much, and it's an honor to have you on the show.
It's my pleasure, Lonnie. Thank you very much.
Professor Phillip Levy. Our guest has been Dr. Phillip Levy, Assistant Vice President for Translational Sciences and Clinical Research and Innovation at Wayne State University, and Associate Chair for Research in the Department of Emergency Medicine. That's all the time we have for today. Thank you so much. We'll see you next time on Primary Care.